I think the major thing is to ensure that there is a dialogue where we get to understand what they're thinking and what they're doing. I know I've had that personal experience with my son. To be able to talk through with that individual as to, this is a good thought, this is not a good thought. And to be able to have that conversation is important, being able to say, you are an important member of our family. And when the waiter tells you, or when the voice tells you to do this, that will deem you unsafe, then I need to warn you and tell you, because after all, we do love each other and care for each other as well.
A suicide attempt is a frightening experience for a partner, a friend, or a family member. A person who's attempted suicide is at increased risk of dying by suicide in the future, so some form of treatment is essential. This may include therapy, medication, or a stay in hospital for a while. People who've attempted suicide will undergo a risk assessment by a clinical professional, which involves a lot of questions about a person's thinking.
How long they've been thinking about it, what sort of thoughts they were having, how often they'd been thinking about it. Was there a plan? If there is a plan, what is the plan? What are all the details around the plan? You really want to know that. You want to know what was the method, what was the likelihood that the person had easy access to the means to do it using that method, or what was the likelihood that somebody would interrupt or discover them. You'd want to know if they'd had made an attempt previously. You want to know if they know of other people who have tried to take their lives. Do they have a current mental illness that needs quite active management? And that will be a very common scenario, and most commonly it's a depressive illness.
Positive questions are also asked.
What's stopping you from doing it? Are there some things that have meant that you haven't done it up till now? The good thing about getting that information is that helps you identify some things that you might be able to get the person to work with as leverage for keeping them safe.
If a person is not hospitalised after a suicide attempt, they may be sent home.
If you thought it was high risk, then sending somebody home to be by themselves isn't very smart. They should probably have company, and that might mean somebody going to stay with them, or it might mean them going to stay with somebody else. And it's okay to say to a person, I'm sorry that you don't like me asking this question, but I'm worried about you and I'm going to ask you this question. Have you been thinking about harming yourself? It's got to be okay for a carer to really say that at any time.
Making the home environment a safe place is a high priority.
Really be thoughtful and use your common sense. If there are things around that you think could endanger the person if they use them, then it's best to think about how you can get rid of them. If there are, cords and extension cords and ropes and things lying around, it would be good to get rid of those. People who present to ED with self-harm are quite commonly intoxicated, and particularly with alcohol. You'd want the support person to encourage the person at risk not to go drinking. If you have a firearm in the house, you need to make sure that the firearm is locked away, that the bolt is away from the firearm, and that the ammunition is locked somewhere else and the person doesn't know where the key is. There are people who regret not doing that. Obviously the medication, you need to know where the medication is, and if you've got old tablets lying around in the bathroom cupboard, you need to get rid of those.
For a person that may be on medication following a suicide attempt, this can present a practical problem.
Sometimes you can get prescriptions given in just measured amounts, like a week at a time, so that they haven't got, 3 months worth of medication lying around. There are different ways you can do it, and you need to work in with the people and work out the best way for them.
Monitoring the person's mood changes and responses is particularly important at the early stage of treatment.
One of the issues with medication is it can take, 2 weeks to really start to have any clinical effect. It's important to keep seeing the person in that 2 weeks, or at least keep contact with them for the clinician. And that's something useful, I think, for family and support people to know, that it's not sufficient just to prescribe a medication for somebody who's been suicidal and then get them back in 2 weeks.
A sudden improvement in the person's mood during this time should be seen as a potential warning sign.
But when a person's resolved to kill themselves, they sometimes feel lighter. If it was a pretty sudden turnaround in a person who had been quite actively suicidal and nothing, it was perhaps early in treatment, you wouldn't want to assume that it was a treatment response.
Sometimes you may need support to start having these conversations. You can call helplines such as the Samaritans or Lifeline, or an organisation like Supporting Families. You can also ask your loved one's clinician for advice.
I would encourage people to, negotiate with the person that they're supporting to be allowed to come along to an appointment and maybe, come in for the last 5 minutes and ask some questions and get some information.
If a person's deemed to be at high risk, they may have to spend time in a mental health unit. Much like intensive care units, the experience of visiting a loved one here is quite different to an ordinary hospital ward.
Mental health units are usually quite busy places, and the people in them aren't very well. It's important that families in particular have some expectation of that.
When it comes time to be discharged, carers should be part of the planning process with their loved one and their clinician to help build a bridge to recovery, whether it's contributing around the home or negotiating a return to work. Being active is important.
It's also important for carers not to hover. Sometimes it can be useful for the carer to maybe have a discussion with a mental health professional about, ways of being helpful, ways of being supportive that don't involve the patient experiencing hovering. That can make people feel really anxious and just as if they've got no sort of space, and especially if they've been in an inpatient unit. One of the things they're probably looking forward to is having a bit of space.
If you'd like more information about caring for someone who's suicidal, visit www.spins.org.nz. If you want advice or support, you can contact a branch of Supporting Families in your area. Ka kite.